called insulin dependent diabetes mellitus. Means here treatment is only insulin. Then a second type is non-insulin. We call this NIDDM. Non-insulin means here first you will give OHA. If it is not controlled on OHA, then you will give insulin. Type 1.5 like is a type of diabetes which is a mixed form. Then we can have LADA. LADA is your latent. So type 1.5 will have features of both type 1 and type 2. Latent autoimmune diabetes of adult. Then we have MODY, like a maturity onset diabetes of young. MODY is maturity onset diabetes of young. They ask you a question on MODY, like we have different types of MODY. Out of this, remember, most common type is MODY 3. And this MODY 3 is at chromosome 12. Chromosome number 12. And this MODY, understand, this MODY is due to a mutation of a gene that is called HNF. HNF is hepatocyte nuclear factor, HNF1 alpha. So this is the gene that is mutated in MODY. Then if I talk about type 1, this type 1 is due to CTLA4 gene. So type 1 is also autoimmune, that is CTLA4. Type 3 diabetes, remember we also call this brain diabetes. Brain diabetes or diabetes that is seen in a patient with Alzheimer's disease. In a patient with Alzheimer's disease or brain diabetes. So these are some forms of diabetes. Now understand this, these are some syndrome, Cushing syndrome. So Cushing syndrome, there is more cortisol, acromegaly, there is more growth hormone, pheochromocytoma, that's a tumor of adrenal medulla, somatostatinoma and glucagonoma. These are conditions which are associated with diabetes. Or I can say these patients are prone to develop diabetes. So for example, Cushing syndrome patient, generally these patients are pre-diabetic or diabetic. Similarly, acromegaly people, they are at risk of developing diabetes. So these are few conditions which you have to remember, which are other, and I can say other endocrine disease associated with diabetes. Then you can see like there is a list of drugs. So out of this you have to remember steroid, then L-asparaginase. Then many Ayurvedic medicine, they have a sugar containing syrup, especially honey. So in many companies they sell honey, but instead of honey, what they add sugar syrup. Even many cough suppressant, cough syrup, they have honey. So these are I can say these are the drugs which can cause diabetes. So most common cause of diabetes, most common cause of drug-induced diabetes is steroid. Like in COVID first wave, second wave, we have given a lot of steroid. But unfortunately, one sad thing is like we made many patients pre-diabetic or diabetic. Like I'm having few patients who are coming in follow-up with me. So previously they were having a normal blood sugar, but they were admitted for 15 days or 10 days, some people for 20 days. And somehow they survived the COVID, but now they are diabetic. So steroid, these are most common cause. Then L-asparaginase is important. So like L-asparaginase we use in a VAPD regime. Regime we use to treat ALL. So this is used to treat acute lymphoblastic leukemia. So this can also be a potential cause of diabetes. Then phenytoin, antiepileptic drug, beta agonist, tacrolimus, sirolimus, these are immunosuppressants, thiazide, olanzapine, protease inhibitor, nicotinic acid, and some sugar containing syrup. So these are some of the causes of drug-induced diabetes. Then we have a patient who is having abdominal obesity. So how we can grade abdominal obesity, understand? Abdominal obesity means you are measuring like abdominal girth with inchy tape. So you can see the diameter is more than 102 centimeter in case of male and 88 centimeter in case of female. Triglyceride levels are more than 150 in both sex. HDL levels are less than 50, less than 40. Fourth is blood pressure, which is more than 140/90. Fifth is fasting blood sugar is more than 110. So it means more than 110. So 110, I can say 110 to 126. That's called pre-diabetes. So these are 5 features. So let me write these 5 features again in a simple way. So patient who is having either diabetes, means fasting is more than I can say 126, or fasting is in the range of 100 to 126, that is pre-diabetes. Then patient is having hypertension, you can clearly see like patient is having BP, hypertension. Then patient is having obesity, and how we have graded obesity by measuring abdominal girth. Then patient is having lipid, so which lipid? So if you see lipid means first I talk about HDL, so this lipid HDL is decreased. Then I talk about next lipid, that next lipid is triglyceride. So HDL, LDL, VLDL, all these are lipids, so triglyceride is increased. So these are 5 features. Now look at the screen very carefully. So I am writing here DOL. So understand this DOL. If you see 3 or more features, if 3 or more are present out of these, if you see any 3 or more are present, this is the diagnosis of metabolic syndrome. Metabolic syndrome, or we call this syndrome X. Metabolic syndrome or syndrome X. Clear? So they ask you like examiner favorite topic, we call all are feature of metabolic syndrome again, and I'm expecting questions in this attempt in INICET or FMG or NEET PG exam with this topic, metabolic syndrome. Now suppose you are having a patient who is having metabolic syndrome. So this syndrome X, and if this person who is obese, right, who is having diabetes or pre-diabetes, and this person I can say this is a person who is having a cessation of breathing when he is sleeping. That is called obstructive sleep apnea. Obstructive sleep apnea. So this is what we call this as syndrome Z. So syndrome Z is a new entity already asked in INICET exam. So syndrome X plus OSA, we call this syndrome Z. Clear? So this is metabolic syndrome, and remember metabolic syndrome patients, they are prone to develop diabetes. Now rhinocerebral mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis, then this is very very important, and ENT, favorite MCQ, malignant otitis externa, which is caused by Pseudomonas. Then infection related glomerulonephritis. So these are something which are, I can say, infections which are unique in diabetes. These are infections, so they can ask you like which patient, if you have seen like mucormycosis, so most of these patients were diabetic. Infection which are unique to diabetes. So these are the diseases which are in, I can say 90% of the time patient is diabetic. So mucormycosis can occur because of many other reasons, but the most common patient is diabetic, right? Now in diabetes, when I talk about 2 important complications, so these are like 2 acute complications. So just I'm writing there, writing here 2 acute complication, or I can say these are emergency. So first is DKA, diabetic ketoacidosis, and second is diabetic non-ketotic hyperosmolar coma. So just try to understand these 2 complications. If you see DKA patient, so here you will see like a blood sugar will be in the range of 300 to 600 milligram per deciliter. And if you see in coma blood sugar will be more than 600. So sometime like glucometer, they cannot interpret the higher readings, so they will write you HI means high means it's not they are waving you, it's HIGH. So this is means high, HIGH means glucometer, they cannot monitor reading beyond this. The next thing, remember in DKA blood sugar is in this range, then in coma you can see it's more than 600. Then to make a diagnosis of DKA, so DKA, all these 3 features are needed. So D is diabetes, patient should have diabetes, so diabetes range blood sugar. K is there should be ketone bodies, present. A is acidosis, and how we can get acidosis, how we can get an idea? For this we need ABG sample, and there you will see pH is low. So these 3 things are present, so patient should have diabetes. In coma you can say patient will be diabetes, right? Patient will be diabetes, but these two things are absent. There are no ketone bodies, and remember, very, very important, in coma, there are no ketone bodies. Let me write Kb, and there is normal pH. Normal pH. So if you ask me like, sir, how this DK patient will come to you, so they can present with multiple complaints. For example, they can come to you with tachycardia, they can come to you with tachypnea, they can come with abdominal pain, they can come to you with shortness of breath. So these are common findings. And even sometimes they can come to you with altered sensorium. So means there will be like altered mentation or altered sensorium. And I can say these patients sometimes they can come to you with chest pain. So when you see them, like they will have a rapid breathing. That is what we call it Kussmaul breathing, which is due to acidosis. Kussmaul breathing. Do not confuse this Kussmaul breathing with Kussmaul sign. Kussmaul sign we see in cardiology. This is Kussmaul breathing. So these are the symptoms. And coma, you can see these patients will not come with this finding. Somebody will bring this patient. The patient is like in vegetative state in coma. Simple. The point is how we differentiate. In DK, you will see less dehydration. In coma, there is more dehydration. So treatment of choice in both the condition. First, we have to give aggressive IV fluid. And the fluid of choice, do not give dextrose, no DNS, we give only NS, normal saline. When we give a normal saline, then straight away what we give, after this what we give insulin. And insulin, remember, bioavailability of IV drug is 100%. So we prefer to give regular insulin. So we give a regular insulin, we give IV fluid, right? Then in DK patient, understand, in DK patient having a low pH. So just let me add here, soda bicarb, we give only in DK. And fourth thing is remember, insulin can decrease potassium, so we can also give KCl supplementation. So soda bicarb we give only in DK, other things we give in both. Then we continue, remember, then last thing is we continue IV fluid and insulin via infusion. So this is how we manage DK and coma, right? Now the question they ask in exam is, what is cause of death in DK? The cause of death in DK is cerebral edema. This is cerebral edema. So this is something which you have to remember. These are acute complications, right? Now coming to a chronic complication. So let me just add a word here, chronic complication. So in chronic complication, we can have some microvascular complication like retinopathy, nephropathy, neuropathy, and macrovascular. So in retinopathy, I can say patient can develop some sort of hemorrhage. So there can be hemorrhage in the eyes. There can be a non-proliferative retinopathy, just I am writing NPRP, or there can be proliferative retinopathy. In non-proliferative retinopathy, patient will develop cystoid macular edema. And in proliferative retinopathy, patient can develop attractional retinal detachment. Fractional retinal detachment. So this will lead to visual impairment. So they ask you like, what is the cause of visual impairment or blindness in a patient in non-proliferative phase? Answer is CMA, cystoid macular edema. And this attractional retinal detachment, this is the cause of blindness in a person, blindness, or I can use the term visual impairment in proliferative stage. Coming to nephropathy, so diabetes is most common condition which is causing CKD. Remember, as I'm writing this, diabetes is most common condition that is leading to CKD. They ask you MCQ like, what is the earliest finding? Earliest finding is microalbuminuria. Earliest finding is a small amount of albumin is released. Then a patient can also develop a neuropathy. So we have different, it can affect small fiber, large fiber, medium fiber, it can affect a sensory fiber, motor fiber, autonomic fiber. The most common type will be diffuse, symmetrical, polyneuropathy. But remember, any type of neuropathy is possible in diabetes. Diabetes can cause any type of neuropathy. So in autonomic neuropathy, you have to remember patient can develop postural hypotension, there can be sexual dysfunction, right? There can be bowel and bladder involvement. Then CAD, remember CAD, so diabetic patient, they can develop silent MI. So they can develop heart disease, they can develop peripheral vascular disease like they are as to develop a DVT, they can develop peripheral gangrene, and there can be I can say cerebrovascular disease. So in diabetic patient, they can develop stroke. So they can develop ischemic stroke. They can also develop brain hemorrhage, that is hemorrhagic. So diabetes patient, they can develop both ischemic as well as hemorrhagic type of stroke. In ischemic, we have like embolic stroke and lacunar stroke. These are two common stroke that we see in diabetic patients. So these are the chronic complications. Now, diabetes patient, if you see their skin, you will find some changes in the skin. So what we call this as diabetes dermopathy. Diabetes dermopathy. So diabetes patient, there will be some skin changes. So what are these skin changes? Understand this. Necrobiosis diabeticorum, lipotica diabeticorum. So you will see there will be lipid dysfunction. You can see there is I can say because of insulin injection at the same side, or sometimes because of some subcutaneous drug, patient can develop this. Acanthosis nigricans, there is a blackening of the skin in the neck. In the neck area, you can see blackening. There can be spots in the tibial area. We call them shin spots. Then there can be edema. Pay attention. I have not written scleroderma. It is sclerodema. So there can be like edema in the lower border of the neck. That's called sclerodema. There can be pigmented purpura, eruptive xanthoma. There can be xanthelasma because of dyslipidemia in diabetes patient. And they can develop a rash that is called granuloma annulare. So these are the things which we see in diabetes skin manifestation. We call them diabetes dermopathy. Diabetes dermopathy. So important, which you have to remember for exam is granuloma annulare, acanthosis nigricans. Acanthosis nigricans is non-specific. You can also see this in many obese person. Then necrobiosis lipotica diabeticorum. Okay, coming to treatment of diabetes. So what we can have insulin. So remember, insulin in type 1 diabetes, in type 2 diabetes. So understand, in type 1 diabetes, in type 1 treatment is we give insulin. In type 2, first what we give OHA. If there is no control with OHA, then we switch to insulin. So based on our duration of action, we can have a short-acting insulin, intermediate-acting and long-acting. So short-acting insulin, what we have, we can have short-acting insulin like Lispro, Aspart, Glulysin. Intermediate acting will include NPH. So sometimes they ask full form of NPH. It is neutral protamine hagedrone, and regular insulin. Then long acting we have Glargine, Detemer. There is one more, Degludec. Glargine, Detemer, and Degludec. Now how to remember this? Look at the screen. Like if you see short acting is having S, Lispro is having S, Aspart is having S, Glulysin is having S. So all short-acting insulin, they have S in the name. And if you see carefully, so I want to show you this carefully. See this very carefully. Nowhere is S in intermediate, long, NPH, regular. Nowhere it is S. Look through my eyes, right? Now see, intermediate you can remember by simple mnemonic INR. You know INR, international normalized ratio. So INR means intermediate, NPH, and regular. What is long? Long is distance. Long is distance. So long distance relationship, D for distance, D for Degludec. And synonymously, I can say like long or large. So you can see here large, LARGE is little far. This is large. See, ARG is here. Simple. So they ask you like all are short acting except all are long acting except. So out of this, remember, only insulin which we can give IV, that is the regular insulin. So they can ask you like which is the insulin which we give in emergency. So in emergency like in coma, in DK, which insulin you will give? You will give a regular insulin. Very, very important. Otherwise, all other insulin we give by subcutaneous route. All other we give by subcutaneous route. And nowadays, remember, what we have a new type of insulin which we call them inhalational insulin. So just let me write here. Inhalational insulin means these are available in powder form. So these inhalational insulin, understand this. We have drugs like Afrezza and Exubera. Afrezza and Exubera, these are inhalational insulin or in powder form. So this is about the insulin that you should know. Now coming to OHA. So OHA we prefer to give in type 2 diabetes. So we start with bigovanides. So bigovanides, we have drugs like metformin, fenformin. Fenformin. So metformin, fenformin is no longer used. So this is like a dead drug. We no longer use this because this can cause lactic acidosis. Side effect is lactic acidosis. Even metformin will also have a little chance of causing lactic acidosis. So they ask metformin can also cause. But fenformin causes a lot of lactic acidosis. So that's why this drug is banned. It is no longer used. So metformin, they ask you MCQ like where else we can use, or what are metformin means. They ask you like when to stop this drug. Like, so remember, when GFR is less than 45, we should decrease the dose. When it is less than 30, we should permanently stop this. So that I think already discussed in nephrology. So what else they can ask you? They can ask you other side effect of metformin. So metformin, remember, the side effect of this drug is this can cause B12 deficiency. Very, very important. It can cause B12 deficiency. Then remember, metformin, this is the cheapest and worldwide most common used USA. Why? The reason is one is cheapest, money is the main thing. The next main thing is it do not cause hypoglycemia. It will not cause hypoglycemia. That is why it's very, very important. And when I talk about weight, remember, this will cause weight loss. Diabetes patient, they are they are angry always on this thing like I'm gaining weight. So they will cause little weight loss. Then we have sulfonylureas. So we have sulfonylureas like tolbutamide, chloropropamide. These are older generation. So again, these are like rest in peace, no longer used. Nowadays we use sulfonylureas which are starting with G dot ending in IDE. Glimepiride, glibenclamide, glipizide, gliburide. These are all sulfonylureas. The side effect of sulfonylureas, remember, of any sulfonylureas, the important side effect is they first they are hepatotoxic, and they can cause weight gain. Then we can have meglitinide, like rapaglinide, neplitinide. They are not that commonly used, so they are like add-on drugs. So again, not routinely used. Thiazolidinedione. So here we have drugs like rosiglitazone, pioglitazone. So here there is some risk of bladder cancer. Alpha glucosidase inhibitor like acarbose, voglitibose, omegletol. So these are the drugs. Remember, they can cause osmotic diarrhea. They can cause flatulence, and these drugs, remember, they will control postprandial sugar. They will control postprandial spike. So we can add this drug. Suppose patient is taking metformin, still you can see after lunch sugar is more. So in that case, you can add like voglibose or acarbose 0.3 mg. We can add. Then remember, this problem with this drug is these are causing flatulence. They can cause osmotic diarrhea. So they are absolutely contraindicated in a patient with IBD. In a patient with inflammatory bowel disease, you should avoid them. Then GLP-1 analog like glucagon, like peptide, exenatide, liraglutide, good drug, best drug. The only problem is very expensive, so not commonly used in India. The problem is these are subcutaneous drugs. These are not oral drugs. These are not oral tablets. Only a new one is there that is available in oral form. but others are not oral, right? Now, this liraglutide is having an advantage over other GLP-1 analog. Like this is approved as anti-obesity drug. I repeat my statement: metformin can decrease weight, but metformin is not approved for treatment of obesity. Liraglutide is approved. DPP-4 inhibitor like sitagliptin, vildagliptin, tenagliptin, and one more I'm writing here, linagliptin. Linagliptin, last in a live class I told this can be asked, and this question came in exam. So this I told before this question came. It's very, very important advantage, because examiner will think like a doctor. They are practicing physician, so they'll ask you those questions which we are using in practice. So linagliptin generally we give to which patient? We give to those patients who have deranged KFT. So this can be given. So this drug will not need renal dose modification. So you can give this. We can give without, or I can say we can give this. This is like a drug we can say safe in CKD. Safe in CKD or any patient who is having a deranged KFT. Then amylin analog again not routinely used in India because two reasons. Indian people, they don't like subcutaneous drug. Second is we don't like expensive drugs. But remember this, you can also use, it is also approved in type 1 diabetes. This pramlintide can be used. Even acarbose can also be used, but again acarbose is not that effective as a pramlintide. Can be used in type 1 diabetes. Then this is the game changer, SGLT2 inhibitor, canagliflozin, dapagliflozin, empagliflozin. So these are the drugs which will have huge benefit in some respect, some risks. So remember, diabetes patients generally they will die how? They will die by either heart failure, or by kidney failure, or by stroke. These drugs prevent all these three. So they will prevent coronary artery disease, they will prevent CKD, they will prevent cerebrovascular disease. So that is why they are the game changer. In long term, there is some risk of UTI with them, and patient can develop euglycemic ketoacidosis. Means patient sugar is normal, and even some males can develop Fournier's gangrene. So UTI is important. This was the recent NICT question. What I want to add here is like a line which I'm writing here, like canagliflozin and empagliflozin, SGLT2 inhibitor. They are also approved for heart failure. They are approved for heart failure. So even in non-diabetic, I repeat my statement, in non-diabetic, even in non-diabetic. So sometimes you will see like patient is not having diabetes, still cardiologist or MD medicine physician, they are giving them what? SGLT2 inhibitor, because they prevent heart failure. Very, very important. Now coming to opposite of diabetes, what we have? Hypoglycemia. So hypoglycemia can occur due to many reasons. So we have like it can be like, I can say it can occur due to OHA or excess consumption of insulin. Then this can occur because of insulinoma, right? So whenever a person is coming to hypoglycemia, we make a diagnosis by this triad called Whipple's triad. So in Whipple's triad, we have three things. First is like a patient will have symptom of hypoglycemia. So patient will have symptoms of hypoglycemia. When you check his or her blood sugar will be low. So blood sugar is low. So suppose blood sugar is coming 40, 45, 50, means anyway less than 70. So in that case, whenever you give, suppose you are giving any biscuits or I can say fruity, maza, slice, or nothing sugar, or we are giving IV fluid like dextrose, then you can see symptom will improve. So there is resolution of symptoms on giving glucose. So this is what we call this as Whipple's triad. Very, very important. And this is, I think it is not a difficult as triad what we see in surgery. In medicine, triads are simple. Patient is having a symptom, patient sugar is low, give glucose, symptom is over. Insulinoma, it's a tumor which can cause this. Then how we differentiate? Remember, normally what happens, if you see, suppose most of the time what happens is like a patient have taken either sulfonylureas. In OHA, important is sulfonylureas. So possibility is might be my patient have taken overdose of sulfonylureas or insulin. So suppose if it is due to more insulin, so insulin can be more in both insulinoma as well as I can say exogenous administration of insulin. So suppose you prescribe the patient to take a 20 unit of Lantus. Lantus means a long-acting glargine, suppose. But patient on his own or listening to some other doctor or his like a relative, he is himself giving himself, I can say 25 unit, and he is having hypoglycemia. In that case, how we can differentiate? We can do a test called C-peptide. So normally C-peptide, remember C-peptide will release along with insulin. So just try to understand this. Insulin is more and C-peptide is more. It means it is endogenous insulin that is released. So this is a case of insulinoma because they both are released together. But if you see only insulin is more, C-peptide is decreased or normal, it means inside body is not releasing insulin. It is you have taken insulin from outside. So this is a case of, very good, come on, what it is? This is the case of exogenous insulin. Exogenous insulin. So this is about the hypoglycemia that you have to remember. Clear? Whipple's triad is very, very important. And whenever remember hypoglycemia, normally how we define when blood sugar is less than 70, and if it is less than 40, then patient will develop a CNS symptom. And the CNS symptom, what we call this neuroglycopenia. We call this as neuroglycopenia.